Hello, I'm Jeff Pippinger. I am a pharmacist at Eufaula Pharmacy. I'm a former owner as I sold my two pharmacies last year that I had remaining, Eufaula and Shakota Pharmacy. I sold my two pharmacies last year because I was faced with a decision. Okay, after 20 years of building pharmacy business, I could not see a way forward where my assets would increase. I enjoy the entrepreneurial aspect of pharmacy, and during my tenure as pharmacy owner, we went from a small pharmacy operation to a pharmacy that provided IV therapy, compounding, durable medical, pharmacy consulting, long-term care pharmacy, sequencing, unit dose packaging. We tried to provide it if it was available. We provided service and expertise. Now, PBM encroachment has always been there. Their practices of patient steering, egregious auditing, DIR fees, and below-cost reimbursement had finally got to the point that I couldn't see a way through and provide the services that we wanted to provide. There are so many issues, okay? But for Senate Bill 821, I will focus on transparency and patient choice. Now, I'm giving you my story, but this is a story of many pharmacies, okay? I chose to sell. I had the opportunity, and I was in a position that I could. Many pharmacists are not in that position. They might have a lot of debt, trying to figure out how to get through. For me, I was in a different position, so I've made that choice, okay? But I felt forced to make that choice because I loved what I did. I loved owning that pharmacy. But back to patient choice. The closest pharmacy, chain pharmacy to Eufaula is about 13 miles from town center. Because of the lake, though, for most, it's much further. CVS and Walgreens is 30 miles from town center. So to go to those pharmacies at a minimum of 26 miles round trip or up to 60 miles to the other two. So when our patients are steered to those pharmacies by differential copays or by phone calls saying they need to go to the preferred pharmacy, it creates stress and confusion for our patients. Many of our patients are elderly. We do have quite a bit of state employees there in Eufaula because of being the center of McIntosh County. So PBMs also force their patients to mail order. Many times it's been that they can fill the first two at the pharmacy, and then after that they have to go to mail order, and they do by requirement of that, or they do it by copay differentiation. It isn't about the service, and mail order pharmacy is the waste with mail order is well documented. But again, it creates problems for the patient. Mail order doesn't come in on time many times, or orders didn't arrive to the mail order facility in time, and maybe it wasn't their fault, but maybe the orders just didn't come in, and the patient is left without meds, okay? Then they're forced to go without, or, they get to go to their local pharmacy, and the pharmacy now that they have their broken relationship with because they went somewhere else, which then adds stress to the pharmacy because now we must solve the problem. We could say tough luck, but it's not our ethos. We help. Is it the patient's fault? No. They feel that they have no choice. And if you've read any of the letters, many of the letters are somewhat, because of the way they're worded, they don't feel that they have a choice. So, what's this? The other thing that's tough is when we see this patient steering, so patients don't feel like they have it. You just see patients disappear, and then they come back, they start asking more questions, but maybe you don't get them back. Maybe you just see them when they have problems. Makes it a tough environment for pharmacies to exist, having to justify why your cost might be different. But that brings us to another problem, and things that we see is the PBM reimbursement. And because of this patient steering, a lot of times in our EOB, the total cost is the same. It's just the way the payment is organized. Periodically we'd have a patient bring in their EOB and you'd scratch your head, go, total cost is very similar. One of the hard things about, the copays, and we're looking at, and I'll give an example, is a patient might have a $20 copay. On the receipt, it'll say the insurance paid $0. Okay? Pharmacy only made $10 though. We only got paid $10, and $10 went back to the insurance company. So patient paid $20. I only got paid $10, which with my cost and dispensing fee, and the insurance company made $10 for shaking hands. Kind of difficult to tell them. And now, besides that, if I go on to tell the patient and they go to complain, I could have violated contract by telling them because of the gag clause. And at that point, PBMs can threaten to take away my contract. So I got to be careful. Sometimes, to be honest with you, I'd tell them and say, don't tell your insurance company if you decide to call them, because they could rip my contract away. And in fact, it's probably one of the reasons today that I am here to present the side of the pharmacy, because I no longer own the pharmacies and the contract is not really my problem versus other pharmacists who own theirs. Okay? There were 7 pharmacies that closed this last year, okay, because of the tightening margins. Pharmacies are fabric of the community, part of the services that are provided by small business. And I'd be remiss if I didn't mention COVID this last year. Small pharmacies, retail pharmacies, independent pharmacies stood in the gap. We expanded our deliveries to 15-mile radius, so people who couldn't get out. We changed to curbside service, and everybody went and delivered out. When people didn't get their medicine, we stood in the gap and took care of that because mail was running slow, or doctors weren't in, or doctors were sick with COVID. I spent 5 days in the hospital for COVID myself. Our pharmacies all had COVID, 6 of us, but yet the service carried on, and it continued on, and we made sure that people were taken care of. You don't get that by mail order. You don't get that with the chains. Just not there. They're doing curbside service. Don't get me wrong. They're doing that now. But that was there. It had to evolve. We evolved faster. We stood in the gap. Retail pharmacy, especially in rural Oklahoma, is a center that takes care of healthcare, center of healthcare. They have to travel to see the doctors, but the pharmacist is there. And there's just other things as far as surviving. Retail pharmacy is just between donating to small teams and the high school and being part of every organization there is. They have an integral part of the community, not to mention just the healthcare. So that's part of the story and part of the steering. And as you continue to see that they steer away, you'll see pharmacies disappear. I took my opportunity and I stepped off. Okay. I found it interesting in the veto last year. As I was reading the letter, it says Senate Bill 821 attempts to extend restrictions on the management of pharmacy benefits in such a way that it slows innovation in delivery of health care in Oklahoma. Innovation of PBM's business models and profitability, not cost-cutting, not better care, okay? Innovation generally has positive connotations, okay? But here is the high manipulative practices, all right? Innovation, everybody's used to twisting words, and like I said, innovation a lot of times is considered positive, but in this way, it just moves numbers. True innovation would be to bring transparency and to regulate PBM practices. That's what I have to share with you from the retail pharmacy perspective. Open any questions.
Thank you for sharing your story. I think we have a number of questions. I just want to ask, are there any more independents left in Eufaula since you're out?
There's one left. So, and they're working hard to stay afloat.
Do you have CVS and Walgreens in, or a chain, more chain in
No,
there?
they're 30 miles away.
Okay.
You got one you got one of each in McAllister, and you got in Muskogee.
Yeah, I remember you saying that now.
two
I'm sorry.
Walgreens, yeah.
I have a very similar thing. Jefferson County, they have one pharmacy in Waurika, Oklahoma. And if that thing goes away, that is kind of the lifeblood, the general store of the whole town. And if that thing goes away, not only would it be terrible for that town, but those folks would have to drive upwards of 35 minutes to 45 minutes to get to Duncan.
That's correct.
Because of the odds are everybody in between is going to be gone too in that
Right.
rural part of the state. So thank you for your story. And Chairman?
Thank you, Chairman McIntyre. So I just have one question. You talked about, kind of, well, $10 for you, $10 for the insurance company out of a $20 copay.
Right.
Throughout the medical community, I've heard from numerous people that say that, they've certain times they get chargebacks, things
Sure.
of that nature. So is that something that you experience in the pharmacy, the independent pharmacy? Do you
Absolutely.
experience chargebacks?
Oh, absolutely.
So theoretically, if I was to be the insurance company and I collected $10 of that $20, later on I could probably come back and charge you back.
Sure.
So really, you didn't
make
make
even
any
more
money.
money.
So you didn't even make any money, really.
That's right.
Is that correct?
That's correct.
Thank you.
You're recognized.
Thank you, Chairman. So, I think what not just independent pharmacy, but what pharmacy in general did during the pandemic shouldn't go unnoticed. It's my recollection that patients couldn't get in to see a physician. The hospitals didn't want anyone coming by that was sick.
Yep.
Did you ever close down your pharmacy?
Nope.
Instead, did I hear right? You extended your service area by 300%?
That's correct.
I think it is time that people in the state realize what pharmacy means
Yes.
to the communities that they serve.
Yes, sir.
And thank you for that. I know a lot of independent pharmacies. I don't know any that closed even for a day while the rest of the world lived off Amazon. Independent pharmacy and some chain pharmacies closed for cleaning for maybe a day. But pharmacy in Oklahoma and pharmacists in Oklahoma stood up to COVID where everybody else ran away.
That's right.
So thank you for that. When you talk about mail order waste, would that be in regards to mail order companies telling the companies that they serve that they have 100% compliance because they mail it out 12 times a year?
Well, that's right. There's no doubt about it. That's exactly what happens. And you ask the patient, and they say, well, they just send it. They'll call me and they'll ask the question, and they say, well, sure. So they send it out. And then when we talk about waste, what ends up happening is there's something they'll change, or if a patient dies, they bring in trash bags of medicine to the pharmacy to get rid of. Okay?
They bring it to your pharmacy
They bring it to my
and
pharmacy.
want you to get rid of it?
And they want me to get rid of it.
Okay, because
Okay.
there isn't any reverse distributor for mail order leftover drugs at a home?
That's exactly right.
Okay. Is that a cheap process?
Absolutely not.
It's very expensive from what I understand. Also, is there any study that shows that people take their drugs more often if they get them through mail order, or are we just sending them 12 times a year and paying for them 12 times a year versus from what I hear at an independent pharmacy that you actually get penalized when they don't fill their prescriptions, so it is on you and something that you probably spend money for extra systems and phone calls and extra personnel to make sure folks are actually taking the medication. Is there a lot of communication between your staff and your patients on compliance to actually make sure that those folks are taking the prescriptions versus just mailing it out 12 times a year?
You were right on every topic you touched there. Now, part of it is assumptions, right? Because I don't have to assume when they bring in trash bags that they probably weren't taking all the medicine that was being shipped to them. Yes, we do pay for systems, and whether it was prescribed wellness and it was doing patient calls to ask them if they needed this filled, to where we send all kinds of reminders. It's time to fill this medicine. If you would like us to fill this, let us know. And so they'd tell us that medicine has either been discontinued or that they have more of it. And then it brings up the conversation. Well, why aren't you out? Which would further care, because we can say, okay, well, doctor changed your order. Let's go get a different order now from the doctor. It's important to have that. The other, based upon assumptions, that they have 100% compliance because that copay differential we were talking about. Well, if it doesn't cost the patient very much money, then they're going to just ship it out, and I'll say yes. Share with a friend. I don't know.
Have you ever heard of stories where patients call and try to discontinue the medication because their doctor switched them to a different medication or discontinued the medication altogether, yet they still get it for the next 6 months until the prescription runs out, and then if the doctor doesn't catch it when they refill it, they actually get it for the next 12 months also?
Yeah, not at my pharmacy, right?
Not at your pharmacy.
Not at my pharmacy. It doesn't happen because they don't want to pay for it.
Right, but things that maybe come from mail order?
Absolutely.
Okay. And one thing that you had said earlier about how when a patient is forced into mail order, you said they fill their first 2 here, and then it gets shipped to mail order. Is that correct?
Correct.
Would you say that adding a new patient and a new prescription for the first time is more time consuming and costly to fill that first prescription for a patient or even a new patient, and that you make that up through refills, and that if you are forced to do all that work and you have to do it in 5 to 10 minutes while a patient waits on you versus having a mail order pharmacy that gets 30 days to do that same process, that there's a lot of initial expense there, and then transferring it out is very damaging to pharmacy based on the amount of work that goes on into those prescriptions versus revenue?
Absolutely it is.
That's about it. Thank you.
Representative Newton?
Thank you, Mr. Chairman. Thank you, Mr. Pippinger, for being here. Appreciate you. So I am an optometrist, and of course I prescribe ocular medications often. Do you often find, I know that about 4 or 5 years ago we passed a bill that if they had meet 75% of their deadline as far as the prescription should have ran out, that they can get a refill. Do you find that often, that sometimes they'll run out of drops early and come back and get that refill?
All the time, and for different reasons. One, if they're getting eye surgery, many times they have this surgery on each eye in the same month. They have a new set of prescriptions. PBMs will then block that, and then we're forced to figure out a solution to get that paid for. But secondly, a lot of times when we have patients who have vision problems, they have a hard time getting drops in, and so they run out. Some drops they get total 2.5 milliliters for the whole month, and if they miss and they have a hard time with their hands and whatever else, it becomes a problem. And then we try to work with them. We try to work on day supply. We try to work on doctor's orders and all that in between to help solve a problem.
Follow up. Thank you, Chair.